Uh, well, good evening. On behalf of the College of Medicine, we're delighted to welcome you to this very interesting, I know it's going to be a very interesting talk on the cervical spine. And I would wish to thank George in advance for giving his time to us tonight and for everybody's time, because it's so important. Time is important to everybody, but I know we're going to learn and so many things this evening, and also it'll give us all food for thought. So, George, thank you so much for your time and for your preparation, and we look forward to hearing your presentation. Thank you
Thank
very
you.
much.
Thank you, Sarah, and thank you, Amanda. And thanks also to Dr. Michael Dixon for allowing us to use the College of Medicine as the platform to, spread education to everyone. So, and thanks a lot for all who have joined this evening. I'm George Ampat. I'm an orthopedic surgeon. I work in Aintree in Liverpool. Now we will have question session in the end. So the way I want to do it is we'll have a short, you know, sort of fire quiz in the beginning, just 15 questions, which will take us a couple of minutes. Everyone join in. You'll have to register. Join and register with your first name just to have a base understanding of what is the knowledge level that we are seeing. And subsequently, I'll do the there is no, and please feel free to ask any questions. If you either you can put it on the chat, or if you raise your hand towards the end, you can ask questions, and so that there is no silly or stupid question. I may not be able to answer all your questions, but definitely I'll make the best attempt at answering your questions. I'm an orthopedic surgeon. Though I am an orthopedic surgeon, my main theme is trying to help people without surgical intervention if possible. So that's my special interest. So without much ado, let's start the presentation. So we're going to talk on cervical spine. I presume all of you can see my presentation. Uh, yeah, I press. Amanda, can you see, or if you just?
Yes, George, great. It looks good. Thank you.
Okay.
Yeah, absolutely.
Thank you. So we are going to do the cervical spine.
Yep.
So we are going to look through anatomy, basic science, A, B, C, D, E, F. That's what this is all about. Anatomy, basic science, conditions, diagnosis, exercise, therapy, and functional outcome. So anatomy and slightly expanding on all those, I'm going to look at the bones, ligaments, muscles, and in basic science, we're going to look at proprioception, the nerves, conditions. We are fully looking at 4 conditions because each of those conditions I could spend an hour, but we want to do a quick overview. We want to do neck pain, cervical spondylosis, about whiplash a bit, radiculopathy and myelopathy. Then diagnosis, we're going to do examination and investigations, and exercise therapy, range of motion, motor control, resistance exercises. Then functional outcomes, exercise therapy, a little bit on surgical interventions and whether it is necessary or not. So looking at anatomy, this is how the entire spine is. We have curves. So this is the side view. You can see the top is the cervical spine. And we are really looking at currently the cervical spine from C1 to C7. And the spinal cord goes in the center. So there are blocks of bones. In between the blocks of bones are the intervertebral discs. Behind each block of bone is a circle, ring of bone. And through all rings attached together form a tunnel. And that's through the tunnel that the spinal cord and the nerves travel. And this is looking at it from the front, and you can see there is a vertebral artery that is going through the transverse process. So that also comes out through the C2 and then enters the head and forms the circle of Willis in the head. But this is just a simple anatomy of the cervical spine. This is the cross section, and it is important to see the cross section. So the front here is the cervical vertebrae, and you can see here, this is the facet joint or the lateral masses. And right here is the ring of the spinal canal. And here is the spinous process. So this is the very back, the front, and in front of this is your throat and the respiratory passage. So here is the spinal cord, and from the spinal cord, you have the dorsal nerve root and the ventral nerve roots, and form together as the collective combined nerve root coming out. So at each level of the spinal cord, you have the nerve root coming out. We have 31 spinal nerves on the left, 31 spinal nerves on the right, but mobile segments, we only have 25. Now, we will come through this diagram again because here you have in the cervical spine, you can affect both the cervical, the cord, the spinal cord, as well as the nerve root. So when things affect the spinal cord, it is myelopathy. When it affects the nerve root, it is radiculopathy. So that is why and myelopathy is slightly more dangerous, and that is why a lot of the questions were on myelopathy. Now, this is an MRI scan. An MRI scan, you can see the side view and the cross-section view. On the left is the sagittal view or the side view. On the very front left here is the front. The back here, you can see my mouse is the back or the posterior. This is the top, the superior. You can see the base of the brain, and this is the inferior. And I've labeled it. This is cross-section, and in the cross-section, this is the anterior, the front. This is posterior. This is the left, and over here is the right, as if the patient is lying and you're seeing from the foot end of the patient and the head is away from us. Now, this yellow line tells me where the cross section is on the right. So, same way, if you see the next image, you can see that it's at a higher level, the cross section. So, you're seeing the high cross section at the higher level. And this, you can also change it. You can bring the yellow line to the left and it'll tell us where the vertical cross section is. Now, I've tried to highlight on all what you see as green is the nervous system. So you can see the brain at the top and the continuation is the spinal cord. And now I've labeled all the bones. You can see the C1 is a ring-shaped bone. Then the C2 has got the peg, C3, 4, 5, 6, 7, 8. And in this, we can see up to the T3 vertebrae. And the orange is the intervertebral disc. So you got a block of bone, a cushion, a block of bone, and cushion. Now, if you see on the right, the image has the yellow line has moved slightly towards the right. So it's not on the center of the spinal cord anymore. So it's on the right where the nerve root canals are. So you can see the nerve root canals here. Also, you can see the facet joints on either side. I've labeled them. You can see these are the lateral masses, and in between are the facet joints on the side. At the orange are the nerve roots. Sometimes you can also see the vertebral artery, going through the cervical spine, going into the head. This is the cross section of the cervical spine, and this diagram that I have, the limit that I've shown, or a small the center, is the limit to show you the external muscles and the internal muscles. The external muscles are very strong. So in the front, you have the sternocleidomastoid, and in the back, you have the trapezius. But they are not the main muscle. They are the stronger muscles. But for neck pain, we need to make the smaller inner muscles strong. And I'll explain that why that is important. So these are the strong external muscles, which actually will increase your pain. It is these muscles that become weak. So all exercise program is trying to help these small inner muscles, and why it is the inner muscles need the strength, I will explain later. So now let's look at some basic science. Am I going fast, or are you all able to modify anything? Please put it on the chat. I can see one chat. Let me see what it says. No, there's nothing. Yeah. Hope everyone is any comments on my style so far? Okay. Nothing on the chat. Okay, fine. So let's look at the basic science. So looking at the basic science, we have the brain, and so from the brain is the continuation, is the spinal cord. So everything that is orange is the central nervous system, and the blue is the peripheral nervous system. So if anything affects there are only two nerves in the motor pathway, upper motor neuron and the lower motor neuron. So from the brain, so if I want to move my right hand, when my brain takes a decision, move my right hand, from the brain up to the exit of the spinal cord, there is one neuron, and that is the upper motor neuron. From the anterior horn cell to the muscle in my hand, there is a second neuron, and that is the lower motor neuron. So all what you see as red is the upper motor neuron. All what you see as blue is the lower motor neuron, or the peripheral nervous system. There's something else in the chat. The sound is quite variable. I'm so sorry. I am trying my best. I hope it is not at your end. My internet is reasonable. Let's see some more. Maybe it should settle. And coming to the pain pathway. So we are looking at the three pathways: the pain pathway, the motor pathway, and also the deep tendon reflexes. In the pain pathway, say something, there's a needle pricks my finger, message goes to the first order neuron into the posterior horn cell. From the posterior horn cell, the nerve, another neuron, second neuron starts, that's the second order neuron starts on the posterior horn cell, decussates, goes to the opposite side, goes up to the in the brain, and there it synapses with the third order neuron, which then takes to the cortex. So for sensation, there are three neurons, whereas for motor, there are only two neurons, and I'll show the motor in a minute. The sensation, there are two synapses. There is a first order neuron junction, the second order neuron junction with the third order neuron. In the sensory, there are two neurons because the body can manipulate it. In the sense, if I'm crossing the road and suddenly my ankle twists and I have pain, but I can see a huge bus coming towards me, I will not recognize the pain, but it will still go across because my body recognizes the danger. If I stay on the road, the bus is going to hit me, and it changes the neurotransmitters at that synapses, and I can get across to the opposite side of the road. So that is how it can, that is why more synapses are there in the sensory system. Whereas in the motor part, two, as I explained, there is one coming directly from the brain to the anterior horn cell. There is also 90% cross, but 10% don't cross, 10% come down. That is just to give axial control. And there is a second neuron which starts in the anterior horn cell to the muscle, and that contracts the muscle. So there are only two neurons involved in the motor. And the first neuron is called the upper motor neuron. The second neuron is called the lower motor neuron. So if there is stroke or if you have a problem with the spinal cord, we call it the upper motor neuron lesion. Whereas if it is only with the distal, the peripheral nerve, then we call it as a lower motor neuron lesion. In the reflexes, tendon reflexes are slightly different. It is usually done within the spinal cord, and it is done because, say, when you tap a hammer here, that tendon, suddenly you're lengthening that tendon. When it suddenly lengthens the tendon, it lengthens the Golgi apparatus in the stretch receptors. They send the impulse to the posterior horn cell, then the anterior horn cell sends a signal to that muscle to keep. So that is why it works. But when that reflex arc goes, there is also an impulse that goes to the brain and tells we are actually doing a reflex contraction. Tell me a little bit more to help me. And that's why this anterior horn cell is asking the brain for second help. Now, let me explain why we have reflex action. It is like this. We are humans, we walk in different surfaces, and we may slip and fall. So if we slip, there is suddenly the tendons or the muscles are lengthened. It's the rate of lengthening that matters. Normal lengthening, it will allow it to lengthen, but sudden lengthening, it immediately triggers the Golgi apparatus, sends it to the spinal cord. Yes, we are going to fall. There's something slippery. My leg is being slipped forward. Immediately, the spinal cord says, stop, pull it back. And that is why that the reflex action takes place. But the spinal cord is not very clever. It pull it back too much that you may fall the opposite way. So that is why a second small cortical impulse is sent. So it tells the cortex, the brain, well, we are pulling back. How much should we pull back? Brain says, control, don't pull back too much. And because the brain is controlling, our reflexes are not hyperacute. Whereas if you have myelopathy, there is a compression of the spinal cord, or if you have a stroke, because there is no cortical control, the chance of there is hyperreflexia, and I'll show you some examples. So these reflexes are like the seat belt. The seat belt, if you slowly pull on the seat belt, it will come out quite easily. Whereas if you give a sudden yank, the seat belt locks. So similar is our deep tendon reflexes. If you suddenly lengthen it as you slip and fall, there is a reflex contraction. But if you can slowly, you can stretch it and nothing happens, just like the seat. Now, along with that comes the sensation called the joint position sense. Now, that is not in our normal senses. In normal day-to-day parlance, we talk of the eye, visual, nose, ears, taste, and skin sensation. But there is the joint position sense is significant. Now, as this man is running, as soon as his right foot lands on the ground, we must understand there are a million impulses that is going to his, not to the cortex, but just below the cortex into the cerebellum and the all the motor nuclei, and it tells exactly how the ground is, what is the speed it was going, was it slippery or not. And based on that, the left leg is landing. Now, all those are dulled, especially, say, suppose if you have had an alcoholic drink, we will not be able to run like this because all those reflexes are dulled. So we need that proprioception that goes to the dorsal lemniscal pathway. I won't tell too many. It's on the back of the spinal cord, but we need that, how it lands, the joint position sense to make our next step. Now, as I said, there is the brain, the spinal cord is the upper motor neuron of the central nervous system. The blue that you see is the peripheral nervous system. So in this cross section, this in the front here is the cervical disc. If there is a disc prolapse posterolaterally like this on the corner, then it is going to affect the nerve root. So then it affects the lower motor neuron. Whereas on the other hand, if the disc comes out right in the center, then it affects the spinal cord and it becomes an upper motor neuron lesion. But majority, 90% of disc prolapses go on the side here and affect the nerve root, the radiculopathy. And because it's a nerve root, it's called radiculopathy. But very few, about 5 to 10%, will affect the spinal cord directly. And then if it affects the spinal cord, it is called myelopathy. So what are the conditions we are going to look at? We're going to first look at neck pain. That is very common. So this is how common it is. We can see here the prevalence rate. So in a mean, just now, if you people in population, 7.6% will have neck pain. You ask the general population, have you had pain this year? 7.2% will say that they have had neck pain in the last 1 year. You ask the same general population, ever in your life have you had neck pain? And say 48.5% will say they have had neck pain. So neck pain is very common. Neck pain and back pain is a big cost, and actually in the US they estimate it to be, the cost is to be something like $87.6 billion is the cost of low back pain and neck pain, and it's the third behind diabetes and heart disease. So it's a huge cost effect for neck and back pain, and that's why it is important. Now, this is again the MRI scan of a cervical spine. Now, this is the lady who has degeneration. Now, if you look at the scan here, this disc is okay, it is reasonably hydrated, but these discs are dehydrated. Unfortunately, everyone focuses on the degeneration, but I think that is climbing the wrong tree. Now, they may say there is slightly touching the spinal cord here, but it is not causing any compression, because if you see at the back of the spinal cord, there is adequate space. So I could be touching your hand, but I'm not, pinching your hand. So obviously I cannot be causing you pain. Same way, this is not getting pinched. It is only being touched. So then why is there pain in this patient compared to this patient has also got degeneration, but he has no pain? You can see there is degeneration at all these discs, but this gentleman does not have pain. Now that is important because it is the muscles. Now this lady who has neck pain, she has got very poor posterior neck muscles. So the neck is kyphosed. You can see it is slanting towards the front. Whereas this gentleman here, the muscles at the back are very strong and he is able to maintain the inner lord. It just happened to be a male and a female. Everyone can have strong muscles. Sorry, this example, there was a lady and a male, but otherwise there is no difference. So it is a muscle strength. The muscles need to be strong, and only if the muscles are strong will you be able to maintain the cervical lordosis. If the muscles are weak, you will lose the lordosis and you will get into kyphosis. And unfortunately, MRI reports don't document that, and people will say there is spasm and that is why there is flexion. No, it is because of the lack of muscle strength, and also because of lack of proprioception. I'll come to that in a minute later. Now it is like this. This is like a bow and an arrow. So if you see, this is like the bow. When there is lordosis, it's like the bow. Now the bow will only be a bow. String that connects the bow is strong. If the string is weak like this, bow will become longer or may reverse. So we need a strong muscles at the back to keep the structure of the cervical spine. That is what I'm illustrating here. So you can see here the muscles are strong and maintaining lordosis, but here there is lack of lordosis and it is going into slight kyphosis. Next, second condition we need to look at is whiplash. Whiplash is common. Now, we sometimes think, oh, well, people may not really be having a problem, they may, but it's actually true. Not in this lecture, but in another lecture, I will go through what is the three types of pain. And it is possible that whiplash is a type of pain called nociplastic pain. This is not, I won't discuss this here now, but in a subsequent lecture, I will discuss that. So it is possible, though there is no injury, no damage seen, people will still have pain, and that is natural. They are not lying, they are not fabricating. Somehow our insurance mind keeps thinking that maybe they are just fabricating. No, this pain is real. People who have fibromyalgia, their pain is real. We need to empathize, sympathize with them, and then help them. Now, this article, whiplash disorders, talks about the chronic damage that can happen and the chronic pain that some people go through following whiplash associated disorders. And it says it's possible it is through nociplastic pain or other mechanisms that we have still not really understood. Now, the next condition I would like to talk about is cervical radiculopathy, or because of the cervical disc. In this, in neck pain, you may only, because of the weakness of the muscle, you may only have neck pain. But when the disc has come out, you will have both neck pain and arm pain. So if you be in the neck, it may be down the shoulder or down in the arm, and that is what will happen. So if you look at this MRI scan, you can see here, you can see the brain here, the spinal cord continuing here, and you can see this is 2, 3, 4, 5, 6, 7. Between the C6 and C7, there is a disc prolapse that is here. You can see the same disc prolapse. It is more on the left side, not on the right side. So this patient will have left-sided arm pain, and he will have 2, 3, 4, 5, 6, 7. That will affect the C7 nerve root. So the pain will go to the middle finger of the left arm, and there may be weakness in the triceps. There may be numbness into the middle finger, and maybe the triceps jerk is also absent. But what does happen even if it bulges out? It will heal naturally. 95% of prolapses will heal naturally. You saw the small disc prolapse. See this one. This has got a massive disc prolapse. Can you see this lady? C2, C3, C4. You can see such a massive disc prolapse pressing onto the spinal cord. You can see onto the cross section. Now, two surgeons suggested that she requires an operation, but she was scared. She said, I don't want an operation. I don't want to, have the risks of spinal surgery. Okay, so we treated her non-operatively, and after a year, we took a scan. The disc has gone completely. There is no disc at all. It's all completely resolved. So how did that happen? That happened because she was in a lot of pain, and now she's happy. Why that happened is because what is known as the immune privilege of the intervertebral disc. So the disc has two parts. There's an outer jammy part and outer doughy part and an inner jammy part. It is the jam that comes out of the jam donut. If you it looks like a jam donut. So the jam comes out of the jam donut, hits the nerve. But the body's warrior cells or the macrophages will eat away the jam. Because somehow the body doesn't recognize the jam because it is encased inside the dough. It doesn't recognize the jam. So that is why our immune mechanism can attack the jam of the jam donut and resolve it. So if I show you in a figurative, so that's the blocks of bones, the vertebrae, and you have the intervertebral disc. And you can see just like this, there is the jam donut. So the nucleus pulposus is the jam, the annulus fibrosus is the dough part of it. The disc becomes dehydrated. For a disc prolapse to occur, the disc has to be dehydrated. It loses its water content, maybe some damage initially, and that's how the initial dehydration or the desiccation starts. And once the desiccation starts, that is when the inside the nucleus pulposus, the jam may come out, and you can see how the jam has come out here, or the nucleus pulposus has come out and hit on the nerve root. So here it's not hitting the spinal cord, it's only hitting the nerve root. But that causes a significant inflammation. And when it causes a significant inflammation, the macrophages or the warrior cells come and eat away the disc that has come out. So the macrophages will come only if there's inflammation. So actually, if we give our patients anti-inflammatories like brufen and volaprol and naproxen, you're stopping this warrior cells coming there, because the inflammation is the signal for these macrophages to come and eat away the disc. If you stop the inflammation, so ideally you should not give anti-inflammatories. You give normal painkillers, paracetamol, codeine, tramadol. You can give gabapentin or pregabalin, which is neuropathic agents. Now, let me explain how the jam comes out of the jam donut. So in my house, I'm a bit messy. Jam, if I eat a jam donut, may fall on the table. I don't, my wife will clean it, but I don't clean it. I have some friendly ants in the house which will come at night, eat away the jam, and the table becomes clean. Similarly, when a disc prolapses, we just have to wait, and the body's warrior cells will come away and eat the disc, the jam that has come out. So in cervical radiculopathy, this article also says 90 to 95% of disc prolapses just resolve naturally without any intervention. So the need for surgery is only if it is a worsening neurological condition. The next condition we're looking at it is cervical myelopathy. So it affects the peripheral nerve, the nerve roots, it is radiculopathy, but it affects the spinal cord, it is myelopathy. This is common in old age. Some people can get it in the young. So as they grow old, they have the balance becomes a problem. And they have pins and needles in both hands, and they have stiffness in their fingers. That is their dexterity. Dexterity is the ability to find motor activity, like sewing a button on, putting buttons on, writing, using a chopsticks. These are things which are fine motor activity. People who have myelopathy, where the spinal cord is affected, suddenly say. So if your grandma or grandma says, well, I used to knit a sweat for you every Christmas, but this year I can't. She may be developing myelopathy because her hands have become stiff and she can't knit anymore. And this is the MRI scan of a myelopathy, where you can see the brain, the spinal cord come down, and multiple compressions at multiple spinal canal stenosis. You can see a cross section how the spinal cord is grossly compressed there as it is coming down. Now, again, is surgery required? We look through the evidence, not required. If it is stable, or only if the MRI scans are changed, if it is not deteriorating, surgery is not required. So it's a very common condition, and it is from degeneration, not from anything else. It's normal age-related changes, and it increases with age. Roughly about 70% of the 70-year-olds will have some amount of myelopathy. 80% of 80-year-olds will have some amount. Same way, 90% of 90-year-olds will have. And if you're 100, you'll definitely have some signs of myelopathy. It is so predisposes to progressive neurological dysfunction, and it can cause radiculopathy, can affect the nerve root, or it can affect the spinal cord. And sometimes, very rarely, if they have an injury, they'll get a spinal cord injury called the central cord syndrome. In a central cord syndrome, your upper limbs are more affected than your lower limbs. That is because the way the tracks go. So you can't move your arms, but you can move your legs. And unfortunately, this is a trend that is happening, not just in the US, even maybe here. There is a significant increase in surgical interventions. In the US, the amount of cervical spine surgery increased by 206% between 1992 and 2005. And that is where big surgical giants selling it, like just like how big pharma is selling drugs, the big surgical giants are selling these, implants. So surgery is not to reverse myelopathy. It is only to arrest so that it doesn't become worse. So we should then see whether surgery, the risk of surgery is greater than the risk of the degenerative cervical myelopathy progressing itself. So we have to consider that. And there is limited evidence to inform that with better than non-operative care. There's only one RCT, and that even didn't show that there was any significant benefit from surgical intervention. There is a meta-analysis later, and I'll present that meta-analysis later. So how do you diagnose some of these cervical conditions? So we'll go through the examination part so that we all have a quick refresher of the examination. So one, you need to have a look. Is there sagittal balance? Is there coronal balance? Looking at it from the side, looking at it from the front, and looking at it from all four sides of the patient. Is the head above the trunk and above between the legs? That's what you're looking at. And then you want to feel at the back of the neck, the on either side, the facet joints, the muscles on the side, and see whether there is any difficulties there. Then you want to see the range of motion, lateral flexion to the right and left, extension and flexion, and rotation to the right and left. You need to examine the nerves, so the sensory nerves from, you have 5 dermatomes in the arm and 5 dermatomes in the leg. So you want to see all those dermatomes. I'm sure all of you know it. So just the sensation of these different. The way to remember is the middle finger is the C7 and the great toe is L5 and the little toe is S1. So that's one way of remembering. And then you put the other dermatomes by the side. We want to see the muscle power. Elbow flexion of the biceps is C5. Wrist dorsiflexion, pulling up the wrist, is C6. And pushing the elbow is C7. And, trying to crawl, curl your fingers is C8. And spreading your fingers out is T1. Then you have the deep tendon reflexes. So you have the biceps jerk. You tap on the inside where the biceps tendon is. Same way you have a triceps jerk. You on the outer part of the arm where the triceps tendon. And you also have the brachioradialis on the wrist where the muscles come towards the wrist. That's where you strike on the tendon. There are also some other testing. You can do the temperature testing, hot and cold, and vibration sense. Vibration sense is important because those go through the same pathway, the dorsal lemniscal pathway, where the proprioception goes. So it is important to test whether there is any problem in vibration sensation. But for the cervical spine, there are some special tests. One is the Sperling's test. So if you have a cervical disc prolapse, if you extend the neck towards the side and put pressure down. So as I told you, there are blocks of bones. In between the blocks of bones are cushions. So between two blocks of bones are holes through which the nerve comes out. So the spinal cord is like the motorway in the center, and the nerve roots are the A roads that go on either side. Now, there is also a disc prolapse, and then if you do this maneuver, you're pressing the nerve a bit more, and they will complain of pain down the neck and down the arm. So that's the Sperling's maneuver. But people who have a disc prolapse, they may come to us and say they can keep their hands on their head and say, when I do this, my pain gets better, doctor. So that shows that they have a disc prolapse. Keeping the arm by the side increases their pain, but keeping the arm on the head decreases their pain. There's an AdSense test, but that is not a very good test. It is not really, there's not specificity and sensitivity, but it is mentioned in all textbooks, and it's for the thoracic outlet syndrome, but it is not a good test. Now, someone who has got a whiplash type of injury, one of the good tests to do is the Roos test. So you ask the patient to keep the arms like this, 90 degrees of abduction in the shoulder and 90 degrees of flexion in the elbow, and ask them to flex and extend their fingers up and down. And ask them to do that for 1 minute. If they can't do it for 1 minute, or if they get pins and needles, there can be a soft tissue damage to their nerves and to the brachial plexus or to the nerves coming from the neck. And that is one of the common findings that we can see in whiplash injury. Lehermet's phenomenon. What is Lehermet's phenomenon? It was originally described for multiple sclerosis, but also occurs when there is cervical spine stenosis. That was one of the questions. So if you have a tight canal, so if there is stenosis like what I showed you, the MRI scan, and then you move your neck up and down, you flex and extend, you're pulling the tight spinal canal, you're pulling the spinal cord through a very tight spinal canal. And when you're pulling it up and down, then there are electrical shocks going to your arms and legs, and that is the Lehermet's phenomenon. So if a person comes to you and you ask them to look the head up and look the head down, and they say they complain of electrical shock phenomenon going into the arms and legs, they may be having severe spinal stenosis, and an MRI scan, that is Lehermet's sign, an MRI scan may be necessary. The Hoffman sign is also a sign, it's a sign. If there is compression of the spinal cord, the same deep tendon reflexes become hypertonic. I explained how the deep tendon reflexes was controlled mainly by the spinal jerk. If there was cortical suppression, when the brain and the spinal cord is intact, it suppresses. But when they are not intact, it doesn't suppress. You see this lady, I'm doing the Hoffman sign. As I flick, I'm only flicking her middle finger, but you can see that actually all her other fingers all our other fingers are also contracting. You can see even the thumb is contracting. So this is hyperreflexia. So this is Hoffman's sign. There are two ways of doing the Hoffman sign. This is one way. Otherwise, you can just flick the nail down on the other side also. Then there is inverse radial. You tap on the brachioradialis. Ideally, in normal circumstance, only the brachioradialis should contract. But if you have myelopathy, all the other fingers will contract. You can see in this lady, as I'm doing the tap, you can see the other fingers are also contracting. That is a sign of hyperreflexia because of cervical spinal stenosis. Patients who have stenosis will also have stiffness in their fingers. I told you they won't be able to handle coins. Difficulty. I can't count my coins, son. That means there's some, dexterity. There is an issue. So you ask them to straighten and flex their hands. All of us should be able to do it 20 times within 10 seconds. Now, if you have myelopathy, you won't be able to do that within 20 times within 10 seconds. And again, that is the grip and release test. Clonus it's like a deep tender reflex, but here you are taking the foot and jerking it upwards. Normally, there should not be maybe one beat, maximum 3 beats, but not more beats. But in this gentleman, you can see when I do that, you can see how the foot keeps on vibrating. So that's a clear-cut clonus and a clear-cut sign of an upper motor neuron lesion. Yeah. Babinski's sign, you tell the sole of the foot, the blunt instrument, and what happens is all the toes come together or the toes curl down. And this is a sign that, again, if the curls don't come down and spread apart or the toes go up, that means it's an upper motor neuron sign. There is some either cervical spine stenosis or a stroke. So that's when Babinski's is abnormal. Finger escape sign, make the patient stand with hands forward and all the fingers together. After about half a minute, suddenly their little finger will escape from the rest of the fingers, and that's called the finger escape sign. So what treatment or exercise therapy can we give for these patients who have got cervical problems? Now, generally, many patients are recommended to do stretching exercises. They have stiffness in the neck, but actually, if you make them turn around and like what this lady has been doing, they will increase, the pain will increase. And when the pain increases, they are not going to be compliant. So it's important to tell our patients not to do exercise which increase their pain. And movement itself can increase their pain. And I'll come to why movement may increase their pain. That is because the deep flexors and the deep extensors are not working. So the Cochrane review in 2015 very clearly says ordinary stretching is not good. What we need to do is specific strengthening exercises of the neck, and the scapulothoracic is necessary for chronic neck pain. Now, look at this train. This design of the train works very well. You have the engine and you have a coaches behind. All this works where as the engine moves forward, the train moves, all the coaches move forward. That happens because there is a small link that connects the different parts of the train. So from the engine to the next coach, there is a link. I've magnified the link at the top. So we need that link. So the small link is important for the whole train to have its structure. Now let me give you an alternate design for the train. Instead of the link, let's have another design. The link, let's have a cable like this from the engine to the last coach. Train will work, but you'll see how haphazard it works. The train moves, it pulls the cable, it pulls the last coach, hits on the next coach, that hits on the next coach, and that is how. So the journey is not smooth anymore. Yes, it is, yes, moving forward, but not in a straight line. And that is exactly what happens. Now, this is the image of the cervical spine, the rough shadow of it. There are small muscles very close to the spine, and there are big muscles. These big muscles are the trapezius and sphenomastoid. Now, the difficulty is if the small muscles are strong, there is no problem and there is no issue with pain. But if the small muscles are weak, even if the big muscles are strong, you will get neck pain. And why does it happen? Now, this patient, as they flex forward, you can see it smoothly moves forward and it goes back. So there is no issue with the movement. But unfortunately, if the small muscles are weak, as you flex forward, the big muscle flexes but you can see the vertebrae turning in and out. It's no more in a smooth line like how it was previously. And because it is not in a smooth line, there is going to be friction between the different vertebrae, and that is going to increase the pain. So any exercise therapy should stabilize the extensors and the deep extensors. Those are the muscles that we need to strengthen, not the superficial muscles like the sternocleidomastoid or the trapezius, but the deep muscle. And that is the motor control exercise, because you're controlling the muscles deep inside. That is important. So we looked at the same graph before. So these muscles, you can see the thicker muscles are outside. The thicker muscle here is the sternocleidomastoid, and the thicker muscle here is the trapezius. But we want to strengthen these muscles within the new quadrilateral that I've drawn, and those are the deep extensors and the deep flexors that need to be strengthened. So these are called pillar exercises. You are not moving the neck at all. You are resisting, say, sideways motion, either pushing to the side, flexion to the side, or rotation, or flexion and extension. So there are 6 movements you resist, and that is what is important. Here you can see, cup the hands behind the head, push the head into the hands, and resist the movement. Count for a count of 10. Same way, cup your hands and hold it in the front of the chin. Push your chin into the hands and a hand, preventing that, for a count of 10. Same way to the left lateral flexion and right lateral flexion. Put your hands on the head and resist the movement. So the neck is not moving. Now, when the neck is not moving and you're strengthening, this becomes a neuromuscular exercise or a motor control exercise. Let me explain why. Now, I told you that when we have arthritis, when we have pain, we lose the proprioception from the neck. It's not, proprioception is not just in our feet, it's also in our neck. And when I'm turning to the left, without thinking, I know my head is turned to the left, my head is turned to the right. And my brain actually knows each joint within the cervical spine, how it is moving, how much degrees it has moved. I don't know it consciously, but unconsciously my brain knows it. But unfortunately, that sensation is lost when we have pain, when we have arthritis. By keeping our hands on the head, what is happening is you're getting a new sensation of pressure from the hand onto the head, and that is feeding back to the brain and helping it to regain that knowledge that it has lost from the proprioception. Same way, so there's a chat, let me. So it's pillar exercises. What is the name of the exercises? It is a pillar exercises. Yeah. Yeah. So that's the lateral flexion, and there's a rotation to the left and to the right. And also you can do it with elastic bands. The fact that the band is on your head gives a sensation. And here it is both the deeper muscles that are stimulated more. Yeah. Same on the lateral flexion, you can resist the lateral flexion. Then how do you test whether actually regain that strength? So there are some endurance testing. So cervical extensor endurance. So I want you to see the difference between A, B, and C. In A, they should be able to maintain this position. Here is lying on the couch, head is outside, and head is perfectly parallel to the body or to the ground. So that shows that the deep extensors are working. But in this case, the deep extensors are not working, and the patient's head is slightly tilted more up. So it means the superficial extensors are working and the deep extensors are weak. Here, in this situation, patient stoops down where both the deep extensors and the superficial extensors are weak. Then same way, we have the flexor endurance. You lie on the couch and just lift, not flex forward, just lift the head up. And again, you have to hold for 40 seconds in men and 30 seconds in women. Again, it is showing whether there is a deep flexor endurance. The side lateral neck flexor endurance, you lie on the side, keep the head in the straight position, parallel with the body, so that that gap is there. Men should be able to hold it for 125 seconds, and women should be able to hold it for 95 seconds. Then we know that there is reasonable strength in the muscles. But what are the functional outcomes that we can see? Now, this is a good paper on, whether we need surgery for degenerative, cervical myelopathy. doesn't say that. And especially there may be some patients where we may find an MRI scan shows compression. But if there is no clinical sign of myelopathy, surgery is not required at all. Only in a progressive situation do surgery may be necessary. And again, whether it makes a difference, we really don't know. There is no clear evidence on that. And unfortunately, what's happening is there is an increased trend of needless surgery. Look at this particular case. So this is a 41-year-old male who presented with numbness, pins, and needles. He had an MRI scan, which is like this, showed mild dislocation, and you can see there's a mild bulge on the left side, but not significant. The spinal cord is fine. He saw a spinal surgeon who immediately said, you need a fusion of his disc, and you can see that there is a cage there. You can see the radiolucent dots suggest the cage. Now, he has not got better. He's actually worse off now than before the operation. So we have spent 10,000, the NHS has spent 10,000 pounds on him, put him in an operation, and actually he's in more pain. He was working before the operation, but now he's not working at all. And he has severe neck and shoulder pain. His range of motion is limited, and it's worsened. The symptoms are worsened. And patient is currently undergoing shoulder. I mean, they said, the spinal surgeon said, well, it's not the neck, it's the shoulder now. Now, ideally, they should have seen whether the shoulder was a problem before the surgery rather than do that. And it's quite common. Sometimes is it the neck or the shoulder, is the chicken or the egg? We don't know. Sometimes it's a confusion. So then, and unfortunately, MRI scans are very hypersensitive. MRI scans, it will show age-related changes. I've got a bald head and gray hairs. So my MRI scan will show age-related changes. My face, even with all the aftershave that my face shows my age. If my face shows my age, my spine will also show my age. It is not going to be different. So obviously there'll be age-related changes. Now, considering them, the abnormal is not right because they are just age-related changes. It's like this. If you look at all of you have brushed your teeth in the morning. I don't deny that. You might even brushed it in the evening. But if I get a microscope and look at your teeth, what do you think I'll find? I'll find a million bugs in your teeth. Just because some of the bugs in the teeth are normal, they are normal flora. It's not abnormal. Just because we see bugs, if you keep on brushing every 15 minutes, you need to brush your teeth, and actually you'll be damaging your teeth. Same way, MRI scans are hypersensitive, so we need to be cautious. Now, one way of identifying whether it is the neck or the shoulder is the arm squeeze test, and that is recommended by NICE. So the upper one-third, lower two-thirds of the arm, you squeeze with your hand like this. And if the pain goes down the arm, then it is more likely coming from the neck rather than it's coming from the shoulder. There is some evidence that needless surgery is occurring, and unnecessary surgery is a surgical intervention which is not required. And there is some evidence to show up to 60.7% of spinal surgery is needless and 33% undergo wrong procedures. There is some evidence to suggest that. I'm not saying. This was the same case that we reported, the case report. You can find it in PubMed, and the same case which I just explained to you. But that at only one level. Look at this poor lady. She has got some degeneration, but no real hard signs, and that's the cross section. And another surgeon has gone ahead and put a four-hole plate on her, four-level fusion for absolutely no need at all, unnecessary intervention. We should be very cautious. I can do an operation doesn't mean that we should do an operation. We should be very cautious. And operations, you cannot rectify these problems. And let us look at some functional outcomes. Now, this is, as I said, anterior cervical discectomy and fusion. You can see a plate there. But if you look at it very closely, this plate is coming off. You can see it is loosened up. And again, it is going to interfere with your swallowing. Look at this lady. She had a cervical disc replacement. They said, well, don't use a fusion. The disc is better because it will allow the movement and it will not fuse it. But that's rubbish, because if you really look closely, you can see bone has grown overgrown that disc replacement, and she's got a completely fused segment. And actually, part of the cervical disc replacement has dislodged and it's not in the right position. So a bit wonky. And it is not moving because it is fused. So, all this sail talk that actually it will move is only a sail talk. And unfortunately, the same lady, they did the disc replacement here, but at the higher level now. So adjacent segment disease is an issue in cervical spine surgery. You operate on one level, within 10 years, the adjacent level will fail. It's like a smooth cycle chain. If one part of the cycle chain is stiff, the next level will go. What can we do by exercises? And I said proprioception is important. So there is new type of treatment, the fly is, you have, it's a computer assisted program. So you have this device on your head, you have, and it is, it is a computer program, and it generates different images on the computer screen, and you have to follow because you want to teach the joint position in the joint. So along with strengthening, you hold this and teach the joints. This is another study which talks about exercise, but also with motor image. Motor, so here you can see there is the deep flexors they are activating, but motor imagery is this. So some people who have chronic pain, even if they think they're going to do a movement, it'll hurt their neck. So how do you get them across? How do we get moving their neck? So you do this. This is kinesthetic imagery first. That is, they're thinking what will happen to the joints as they move. Then their visual image. They are imagining how it'll be if they move their neck. Then they have see someone else move the neck or the video of the neck being moved, and they imagine they're moving the neck. Then finally they move the neck in front of a mirror, and that reinforces them. This is when there is severe chronic pain in the neck. And this is the some of the other ways to train is to have a laser point on the top of the head, having a target device and trying to point to the laser device, making a square or whatever it is. This is to see the range of motion, and this again a laser device here. But some good work has come. This is Mohammed Saraj. He is now in Mayo. When he was in Toronto, he did some good work on degenerative cervical myelopathy. Do we need to operate or not? This is a recent paper. Last year it was published. And he said, our review confirms a slow decline. If there is compression, it is a very slow movement. But they managed to get a formula. And based on the formula, actually, the doctors should discuss with their patients. Say something like this. There is a 75-year-old lady. Now, her life expectancy is 12 years. She may live 7 years. And with their formula, by this meta analysis, there is a 45% chance that she will deteriorate. She had severe, stenosis. There's only a 45% chance. Then it is her choice whether there is a 55% chance she will not deteriorate. She may take a decision, I don't want an operation because it's an operation on her knee. So we should be clear because the success is not instantaneous and is not always, guaranteed. So we got to be very careful before we offer surgery. This is Eva Rasmussen Barr from Karolinska Institute in Sweden. And she also did very good work on the exercise programs for the neck. And she did all the different exercises except stretching. They did all exercises. So one is the motor control exercises or the pillar exercises that I told you, keeping the head in one position and resisting that. Or that is where the inner smaller deep flexors and the deep extensors. Pilates, that was also reviewed. Resistance training is just resistance without the pillar exercises. Then you have the TCE or the traditional Chinese exercises, which involves Qigong and Tai Chi. And she also did the systemic analysis. And what she found, all these exercises work. There is nothing superior to any other. Any exercise is likely to work. So show that that all forms will improve. So there's no particular exercise that's better. It is important that we are able to inspire our patients. That is very important. They say the old adage, you can lead the horse to the water, but you can't lead the horse drink. So we need to be as inspirational as possible. Just like if my child doesn't do well, I say, "Oh, you're amazing. You will do well. Even if the child doesn't fails the exam, you're so good. I know next time you will do well." It's the only policy that we can do to our patients. Keep on inspiring them because that is when we can get the best results out of them. Any questions? I'll stop my share. And if you raise your hands, I'll allow you I can get you to talk if you want to raise your hands.
George, I have a question.
Sure.
How popular are you with your other orthopaedic colleagues where you're recommending exercise over surgery?
Well, I'm not very popular, but they also understand that I'm not saying the untruth, yeah. Because, 5 tablets in the morning, 5 tablets at afternoon, 5 tablets at night. You don't need to be a doctor to know that that benefits the shareholder more than the, sufferer or the problem. Yeah.
Thank you.
We have a question, George, that are there any protocols for the pillar exercises in terms of dosage, frequency, duration of isometric hold?
So usually the duration is 7 seconds or count of 10. So if you count, ask the patient, so if I'm going lateral flexion, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So counting 10 is 7 seconds. You do it 3 times, in the morning, 3 times in the evening. And as the questions get, at least 3 to 5 times in a week, daily if possible, but at least 3 to 5 times in a week. If you're giving rest days, don't give 2 consecutive rest days to separate rest days. So you should not have rest Saturday and Sunday. You should exercise Monday, Tuesday, Wednesday, rest on Thursday, Friday, Saturday exercise, Sunday rest. You shouldn't give 2 consecutive days. Do you see a range of spondylitis caused from suboptimal exercise weight training? Spondylosis is, as I said, an age-related thing. Now, if we are supposed to be exercising, we are supposed to be, lifting weights. Much of the problem comes when we are not lifting weights. Like, traditionally we were nature made us hunter-gatherers. So, 500 years ago, my grandfather's grandfather's grandfather woke up in the morning, went to the forest, collected 100 kilograms of firewood, put it on his head, came home, and while he did that, he fought with the bullock, carried the goat home. So we were supposed to do all that. And then the house got washed away. He had to go to the hill and collect some stones and lay the house. So, whereas now the JCB does the heavy lifting and we sit in front of our computers. Yeah, all these exercises will benefit all of us because it will decrease. Strengthening exercises, we need to go into the new world with strengthening exercises because unfortunately there is no more, uh, gracefully aging. We have to age healthily. And it doesn't matter if you're large, it doesn't matter at all. I tell my patients, it's like building. There's a small building, there's a large building. The small building needs 1 ton of cement, 1 ton of sand. The large building needs 10 tons of cement and 10 tons of sand. You can't have the large building with 9 tons of cement and 10, 11 tons of sand, then it is going to fail. The proportion needs to be the same. So same way inside the body, a muscle and fat needs to be proportional. Doesn't matter if you're large, as long as you're the muscle to support it. Yes, exercise need to be indefinitely. We were born because as soon as you stop exercising, you're becoming frail. And we must understand nature wants, we are made recyclable. Nature made us recyclable. We are not plastic. We are not going to exist here for 400 years. And as soon as we stop exercising, we are becoming frail. And the next thing nature decides, this man is old, he needs to die. That's nature's decision. That is how nature doesn't. So, in the world, if the tiger can't hunt the deer, it is starve and die. If the deer doesn't have the strength to run away from the tiger, it is tiger's meat. And that is the rule of nature. So when we become old, if we rest, we become frail, and at our end going to be. And it is important. 100 years ago, our life expectancy, man lived to 50, women live to 60. Now in 2024, man is living to 85, women is living to 95. But we have gained 30 years. But those 30 years, is it in vitality or in disability? If you're a Zimmer frame and you're just hopping from one place to another, it is not vitality. You go to some of the marathons, you see 90-year-olds running. That is the way we need to do. So exercises should be continued indefinitely. I presume you can raise your hands. I've allowed you to raise your hands and you can ask a question.
There was an earlier question that was that you gave the rates of surgery for the United States, and somebody wanted to know if you have the rates for the UK.
Yeah, I think the cost, I think in UK, the cost is 2 billion, I think, 2 billion pounds. But that is again some time back, not the recent one. Yeah.
But I think you gave him percentages.
Oh, of surgery. Oh, no, I don't know the UK rate. Sorry, I don't know the. Yeah, sorry. That is again, that is a couple of papers where they have done a second opinion. They went to a neurosurgeon for a second opinion, another neurosurgeon who he had seen people who were referred to him. Yeah. Please ask me questions. So
I think they've been blown away with so much information.
hope not. I hope it was interesting. And it's
Very interesting. Is there a possibility of you've made a recording? Is there a possibility of those who've attended having the recording so they can
yeah. All
look at
who
it again?
attended, who registered, I will send the recording. Yes. Yeah.
George,
Because
there's a
I
question
think
there about your exercise regime.
Yeah, there is a. I will send you all the exercises. I have, if you have not, my personal request is, hope you see my YouTube channel, like, share, and subscribe. I'll send you my exercise for hip pain, knee pain, neck pain, back pain, and Otago exercise program, which is for older adults. That is one of the routine exercise you could do. Yeah. Thank you. Someone has commented, amazing talk. Thank you. Thank you so much. Yeah. I will, if you're, I'll give you a feedback. You can do a feedback form if you don't mind, or otherwise I can send you later. And we need the feedback, and we will send CPD certificates for people who have registered. So let me share the screen once again. So you should be able to get either the QR code on that, or if you put in https bit.ly/mskcom particular. I will look at the chat. Give me a minute. Someone has put something on the chat. Yeah. Thank you, Jane. Thank you, Cassia. Thank you, Pia. Thank you, James. Yeah, I'll send you all the links. Yeah. Are you able to get to the link?
super. I think we've all had a refresher and actually all learned something new. So thank you so much on
Thank
behalf
you.
of everybody for your time and sharing your amazing knowledge with us all.
Sorry, are you not getting the link? Sorry, are you not getting the link? Is there some?
George, it's got a 404 error on it.
Oh, really? Okay, 1 minute. 1 minute, 1 minute. Let me just correct that. One second. 1 second. Sorry, just give me 1 minute, maybe. Okay, don't worry. I'll send you the link tomorrow. Yeah, sorry. There's some problem. Don't worry. I'll send you the link tomorrow. Yeah, I apologize. Yeah, yeah. I'll send you all email the link. Yeah, and along with the recording. Recording may take a week, a day or two. Yeah.
George, do you
Good.
want to tell everyone when the next one is?
Uh, I do not know the date. I'll again. Sorry, offhand I do not know the date. I'll
Well,
let you know. Yeah.
we'll send out a marketing flyer to everyone. Thank you so much, George. It was so interesting. Brilliant.
Thank you.
Well done.
Thank you, Amanda. Thank you. Thank you so much. Yeah. Yeah.
Thank you so much.
Thank you, Sarah. I hope no.
Absolutely excellent. And My goodness, I haven't thought about some of these things for years. So excellent.
Thank you. Thank you.
Bye,
Thank you so much. Yeah. Bye. Hope no one has any other questions.
Getting a lot of positive feedback, George, in the chat.
Yeah.
Thank you. Thank you. Yeah.
Okay,
I'll send you the link later. Yeah. Thank you.
thank you. Bye, everyone.
Bye.
Bye. Good night,
Bye.
everyone. And thank you
Bye.
again,
Bye.
George.
Thank you. Bye, Sarah. Thanks a lot for coming. Thank you. Bye.
Pleasure.